admitted to Army Hospital Research and Referral, New Delhi on 25th of July 2025. I examined patient on 2nd of August. Informant was self. History seems reliable. Chief complaints. She complains of bilateral lower limb swelling for 2 months, complain of shortness of breath for 2 weeks, and decreased urine output for 2 weeks. Sir, I would like to date back my history in April 2024, when she first time noticed her symptoms. She was a booked antenatal case with obstetric history of Gravida 4, Para 2, Live 2, Abortion 1. In April 2024, at 31st week of pregnancy, she first time noticed bilateral lower limb swelling, which was gradually progressive for 2 weeks. Initial.
At what time of pregnancy during?
Sir, 31st week of pregnancy.
31st week.
And that was 4th pregnancy.
Okay.
Her 4th pregnancy in April 2024, sir.
And before that, you said she had 2 live births.
Sir. And 1 abortion.
1 abortion.
Sir.
Abortion at what period
Sir,
of gestation?
6 weeks, sir.
6 weeks. That was a spontaneous abortion.
Spontaneous abortion, sir. So, in April 2024, at 31st week of pregnancy, she first time noticed bilateral lower limb swelling, which was gradually progressive. Initially noticed over both ankles or feet, and then progresses to involve up to mid-shin over next 2 weeks. The swelling get worsened during the daytime, more in the evening, but does not get completely relieved on rest. Swelling was not associated with any pain in the legs or the redness over the leg skin. So she was visited to her obstetrician as a booked case and with the similar complaints. She denied any history of shortness of breath, orthopnea, PND during the same illness. She denied any history of proteinuria, dysuria, hematuria, decreased urine output. She denied any history of blurring of vision, headache, abnormal body movements. She also denied any history of pain abdomen, frequent vomiting, yellowish discoloration of eyes or urination, or the itching all over the body. She also denied history of skin rash, joint pain, alopecia, photosensitivity. She denied any history of alternative medication intake during the whole pregnancy course or the NSAIDs abuse. During further evaluation by her obstetrician, she was found to have blood pressure of 200 systolic and 100 diastolic mm of Hg on multiple occasions. While her previous BP record during the ANC visit was below 140 by 90 mm of Hg. So she was admitted there as a case of uncontrolled high blood pressure. She was started on oral antihypertensive for 2-3 days, but the blood pressure was not controlled, so she was shifted to IV antihypertensive medication. But her BP remains uncontrolled. So she was further evaluated for uncontrolled blood pressure and found to have hemoglobin, which she remember as 10 value, creatinine as a value of 2, and the urine examination, doctor told her that she was leaking protein, but she could not remember the exact value. So nephrologist opinion was taken, and she was further evaluated by the nephrologist, which was confirmed the same biochemistry finding as the obstetrician, with USG whole abdomen finding suggestive of bilaterally small shrunken kidneys, and she was told to have chronic kidney disease. Her obstetrician further evaluated her for the fetal well-being because her BP was uncontrolled while on IV antihypertensive medication. So her USG for fetal well-being with Doppler suggestive of fetal distress. So she underwent elective LSCS at 32 weeks of gestation and given the birth of a healthy baby boy of 1.5 kg, which kept on ICU for few weeks. During her postnatal period, she required the injectable antihypertensive for initial 2-3 days and then discharged on 2 oral antihypertensive and some other oral medications, which was told for her CKD management, chronic kidney disease management, and her creatinine at the time of discharge was 3.5 with reduced pedal swelling. She continued the same antihypertensive for next 3 months, but the creatinine value was not repeated, and then she switched to alternative medications from July 2024, continued till December 2024. She remembered her creatinine was 7 milligram per deciliter in December 2024, which increased to 9 in March 2025 when she was advised about the AV fistula creation and further need of renal replacement therapy. She lost to follow up to any nephrologist or physician from March to July 2025. On 25th of July 2025, she was presented to our hospital with complaint of bilateral symmetrical lower limb swelling, which was insidious onset, gradually progressive upward up to mid-shin over past 2 months. The swelling was not associated with pain or redness over the legs, but associated with facial puffiness and also swelling over the abdomen. And she noticed as the cloth tightness and gaining weight. She complained of shortness of breath for 2 weeks, which was insidious onset, gradually worsening, initially occur on exertion with MMRC grade 1 to later even on rest with MMRC of grade 4. Her shortness of breath was associated with orthopnea, but no history of PND. There was no complaint of chest pain, palpitation, sweating, cough or hemoptysis. She noticed a gradually progressive decrease in frequency and the quantity of urine output for 2 weeks, which she reported to pass around 200 to 300 ml in 24 hours, which was associated with nocturia but denied any history of hematuria or dysuria. She also complained of occasional episode of vomiting once or twice in a day after the food intake, but no history of pain abdomen, altered bowel habit or the fever. Sir, this is the present history. Then sir.
Okay, complete the rest of the history.
Sir, past history, sir. She had a history of spontaneous miscarriage in 2022 at 6 weeks. There was no other significant medical or surgical history in the past. No history of any recurrent UTI in the past. Obstetric history, para 3, live 3, abortion 1. Her first pregnancy at the age of 19 years in 2010, a normal vaginal delivery, girl child of 2.2 kg. Second pregnancy in 2015, which was also uneventful. Third pregnancy in 2022 with the first trimester abortion but was not evaluated. It was spontaneous abortion. But after that there was no history of fever or dysuria or any hospitalization for the event. Then fourth pregnancy which terminated at given the birth of live child with LSCS at 32 weeks because of the blood pressure control and diagnosed to CKD. Her menstrual history, she achieved menarche at age of 15 years. Previously the cycles was normal, but now she is having secondary amenorrhea. Family history, she is the third born child with non-consanguineous marriage, or all her other siblings and the parents are normal and all 3 kids are normal. There was no significant family history. Personal history, vegetarian by diet, normal bowel habit, altered sleep for past 1 month and decreased urine output, which is now is improving trend. She is taking few oral medications and injectable subcutaneous injection after every session of hemodialysis at present. Vaccination history, she is vaccinated for hepatitis B, influenza, pneumococcus and COVID-19 vaccine. Treatment history, sir. She after admission to our hospital on 25th of July.
Let's forget about the treatment history. So history is complete, right?
Sir.
So can you analyze the history? Forget the investigations or the the reports that she told you about.
Sir.
But just can you analyze the symptoms, the signs, etc. of her presentation and tell us what your interpretation is of
Sir,
all of that?
If we ignore the investigation, especially the ultrasound report during the gestation and the creatinine, so it seems like the pre-eclampsia.
No, just tell me, how do you arrive at a diagnosis of
Sir, because she gave the history of bilateral pedal edema for at the 32 week of gestation, and previously normal blood pressure and now detected.
So when was the blood pressure checked before she was found to have hypertension? What was the interval between the previous visit and this visit in which she was found to have hypertension?
Sir, second trimester she was visited at 20 week she was visited, and then 24 के बाद directly she was visited at 31st week, sir. 24 के बीच में there was the 6 week gap, sir.
Right. And do you know if any other investigation was done at the 24-week visit apart from
No,
physical
sir.
examination,
No, sir.
blood pressure
No other
check, etc.?
investigation.
No
I
other
asked her, particularly husband also told
Okay.
there was no other investigation done, sir.
Right. And so you think she had, the history is consistent with that of preeclampsia, right?
Sir, history wise it's more likely the preeclampsia, sir.
Why do you say it is preeclampsia?
Sir, as per the preeclampsia definition, the previously normal blood pressure and after 20 week of gestation, if there is the two reading 4 hour apart with the blood pressure of more than 140 by 90 mm of Hg, then we consider it as a preeclampsia, sir.
Just the high blood pressure reading becomes preeclampsia?
So, no, sir. Other associated sign or the symptoms, sir, which includes the either the renal involvement in the form of rise in the creatinine value of either more than 1.1 milligram per deciliter of absolute value or more than 50% increase from the baseline, or proteinuria of more than 1 gram or the 3+ in the dipstick.
But we are not considering the investigations, right?
Sir.
So if we don't consider the investigation, can you still make a diagnosis of preeclampsia?
Sir, still we can think because the pedal edema series comes.
Exactly. So because there is no other clear explanation
Sir.
for edema, although edema can
Can be
occur
in
in
the
pregnancy,
pregnancy. Yes,
right?
sir.
So it is possible. But if you give clinical significance to edema
Sir.
in association with the hypertension,
Sir.
then perhaps it leads to a logical conclusion that this might be preeclampsia at that time, right? Even before you do a urine examination.
Yes, sir.
Okay. So then comes the question, this is her 4th pregnancy. How common is preeclampsia in?
So generally preeclampsia more in the nulliparous and with multiple gestation history. This is the multi-gravida.
So what, in other words, if you think of possible pre-existing risk factors, what risk factors did she have?
Sir, one first trimester pregnancy loss history she had, and
is that a risk factor for preeclampsia?
not a direct risk.
Yeah, as such, it's not a risk factor for preeclampsia.
Other than that, sir, she is not having other risk factor.
One, her age. What do you think?
Generally consider more than 40 year more risk, sir. After 30, there are the chances increases.
Chances go up
yes,
as
sir.
the risk increases.
Yes, sir.
That is
One risk factor,
and second is, what about the interval between?
The pregnancy, that is also considered, sir, because her second pregnancy was in 2015 and this is the in 2023. She conceived in 2023. So
Yeah, and that one ended up in just a 6-week abortion.
Sir.
So now she's almost 10 years later, she has this other
sir.
pregnancy. So that is the other one. If we think of preeclampsia as the cause, then that could be the other risk factor.
Sir.
What are the other risk factors theoretically?
Sir, theoretically, maternal risk factor include the maternal obstetric risk factor or the comorbid condition, and then the paternal risk factor. Maternal risk factor in the obstetrical history includes the nulliparous one, multiple gestational pregnancy, and the molar pregnancy. And then maternal comorbid conditions may, sir, they can be the hypertension and pre-existing chronic kidney disease, pre-gestational diabetes mellitus, and paternal risk factor if the father born from the pre-eclamptic mother, that can also consider one of the risk factor. And age, generally in the literature they mentioned as 40 years, sir, but we see in the 30s.
Sure.
A different paternity also becomes a risk.
Yes, sir. And the multiple partners, if the history of multiple partners, then also there is the risk factor. Sir.
That's also a risk factor, for sure. Right. So then, but then, and then what happened? The blood pressure was.
Sir,
what happened to?
After the delivery, LSCS, sir, blood pressure controlled, sir. Initially, she requiring the IV antihypertensive, which.
But she still continued to
sir.
require antihypertensive, right?
Yes, sir.
So what does that mean?
Sir, pre-existing renovascular hypertension.
How can you say renovascular?
After seeing the reports. Otherwise, to sir, it can be the partially resolved preeclampsia.
What?
Partially improved preeclampsia, sir.
Partially improved, is there such a thing? Partially improved preeclampsia?
Sir, otherwise, preeclampsia generally get improved, sir, after the delivery.
So let's say there is a woman, pregnant woman who comes, looks like she has preeclampsia,
Sir.
kidney function is normal at that time,
Sir.
and then she delivers,
Sir.
either because of either induced or even normal delivery,
Sir.
but the blood pressure doesn't come back to normal. What does that mean?
Chronic hypertension,
It means
superimposed
that possibly there is underlying
hypertension
condition, right?
Yes.
It could be hypertension, it could be kidney disease, doesn't have to be renovascular. Renovascular is one possibility, but
Sir.
can be any other
cause.
cause of kidney disease, can be any other cause of hypertension which was simply picked up during pregnancy and led to development of preeclampsia. So that can be one possible factor, right?
Post pregnancy, how many days after you can call it whether it's not an overnight change, right?
Sir.
After the delivery, how many days later or weeks later you can say
Sir, 6 weeks till 6
you should
weeks.
reevaluate.
Till 6 weeks we consider.
After 6 weeks, if it persists, then you can
Then
say
it's
some
a chronic,
underlying. Otherwise,
yes,
till 6 weeks, it could be a part of preeclampsia itself.
Yes, sir.
Yeah, mostly it resolves in the first 10 days, 2 weeks, right?
Yes, sir.
Yeah.
But there is an upper limit of 6 weeks that
Yes.
we still take to label a case as perhaps still, something else, that you have to now look for something else.
Yes, sir.
Okay. So that is what it is. Now, now obviously we have to take into account her investigations, because that is the best you can do with the clinical history. But no, look, okay, let me take it back. Let's say still we don't look at the other investigations.
Sure.
The hypertension has continued, and you know from laboratory investigation that some degree of proteinuria has persisted, the kidney function has not fully recovered.
Sir.
So what are the other possibilities?
Sir,
What else could have happened?
there must be any glomerular disease that now get flared because of the pregnancy, sir. Like lupus nephritis or
Yeah, so one possibility is that the patient developed a kidney disease during pregnancy,
Pregnancy.
right? So
Yes, sir.
some kidney disease developed during pregnancy.
Yes.
That is one possibility. What are those kidney diseases which particularly develop during pregnancy?
Sir, other than preeclampsia, proteinuria is also there in the acute fatty liver of pregnancy in the 3rd trimester, but that is not significant, but can happen, sir.
Yeah,
And-
but that would resolve, right?
Yes, sir.
After the delivery.
And thrombotic microangiopathy. sir.
Yeah, so thrombotic microangiopathy is an important consideration which can occur
During
in
the 3rd trimester or
peripartum,
yes,
yeah,
sir, peripartum
period,
Yes, sir.
postpartum as well.
Yes, sir.
And in that case, you may have persistent kidney dysfunction
Yes, sir.
also. So
that will not resolve with the
that will
pregnancy.
not resolve with
pregnancy,
so, and hypertension is a feature of
Yes, sir. TMS.
there are other things also, but we are not considering investigations for the moment,
Yes,
right?
sir.
What other what are other clues will you have?
Sir, blood investigation, other than blood investigation, sir, we can take the history of skin rashes or petechiae, especially if we are suspecting the TMA, petechial rash,
Petechiae
or
is
the
not, they are not common unless
unless severe thrombocytopenia.
unless the
And
thrombocytopenia is really
neurological
severe.
symptoms, sir. Neurological symptoms, if we suspect the TTP or the renal dysfunction, will be more if the HUS suspect.
So in this postpartum situation or peripartum situation, it is not TTP usually, right? It is
In the
HUS,
trimester, yes.
and neurological symptoms are not very common in that, right? So that's, you should definitely look for it, but it's not likely to be very common.
Sir.
Okay. Any other possibility in such a situation? Anything else that comes to anyone's mind? No, right? That generally covers pretty much everything.
Otherwise,
Do you
sir-
have any other?
Otherwise, sir, if there is any rapidly progressive renal failure causes that.
Yeah, so any primary kidney disease. So we did talk about it. So in particular glomerular diseases,
Yes,
because the patient presented with edema. So
Yes.
edema is a feature of
Any
some
primary
proteinuric kidney disease, which is most likely going to be glomerular disease. So when someone, so forget about pregnancy for a moment. If someone presents to you, anyone, male, female, anyone, with history of swelling, maybe with or without history of swelling, some unexplained elevation in serum creatinine, hypertension, how do you clinically differentiate what kind of disease this might be?
Sir, firstly, the duration of the symptoms we will see, sir. And after taking the history of the duration of the symptoms, we will examine the patient, especially to look for the.
Yeah, you will do all that. You will do. You will take history. You will do physical examination. But what are the parameters that will help you differentiate between various causes of?
Sir, suppose
kidney disease.
if we are suspecting the chronic glomerular nephritis related CKD, so the course will be the robust. The patient will be hypertensive.
So one thing I will encourage all of you not to make a diagnosis of CKD, because CKD is just a classification.
Yes.
It is not a disease per se, right? Any disease can give rise to chronic kidney disease eventually, right? So CKD is not a diagnosis. CKD is just a classification scheme. That is something we should remember. And CKD doesn't help you in offering any special type of treatment to anyone, because if you simply say CKD and then just don't progress any further, then everyone should be treated the same way. But that is not the case. So how will you differentiate between various types of kidney disease in a given individual?
Sir, acute kidney injury and then acute kidney disease and then chronic kidney disease.
Yeah, one is the duration of history will
Yes, sir.
give you a sense whether the disease is acute or
Then-
chronic, but many a times history is short, but the patient will still have perhaps long-standing kidney
Sir.
disease of whatever nature, right? So that and we'll come to that perhaps a little later. But let's say someone has presented with they come and say, yeah, I have. It's not very uncommon when the patient will come to you in the clinic and the patient will say, I have kidney disease, or I have been told to have kidney disease, right? So at that time, if you try to distinguish, because either you don't have enough information or simply as an academic exercise, what kind of kidney disease a person has, how do you go about, what specific questions do you ask, what specific features do you look for?
Sir, we'll look for any nephrotic nephritic features in the history. We'll ask.
How will you
particular-
ask? What
Sir,
will tell you?
History of proteinuria, hematuria, or urine output. Is there is a decrease in the urine output, or any associated uremic symptoms? We'll also.
So uremic symptoms don't tell you what is the nature of kidney disease. It simply means there is advanced kidney failure, right? Anyone has any?
History of renal stones, history of any past.
So the way to approach this is that in your own mind, first you decide how are you going to compartmentalize these conditions, right? So what is it that you are looking for? Kidney disease can be either glomerular in origin, tubulointerstitial origin, vascular, or in something in the urinary tract, right? So these are the big baskets in which kidney diseases can be slotted. So what gives you the reason to suspect glomerular disease much more?
Sir, in the glomerular, the first will be the proteinuria. Sir, patient generally will give the history of either proteinuria or hematuria, and there will be the high blood pressure in some cases.
So the most telltale feature is generally of edema, because proteinuria is fine, but froth can develop even with a small amount of protein excretion in the urine. It doesn't have to be necessarily large degree of protein excretion. right? So if there is history of edema, that very strongly supports possibility of a glomerular disease being there. History of hematuria, but again hematuria by itself can be even due to stones, can be due to something in the urinary tract itself, right? So you have with hematuria you have to also think of other things like painless hematuria, and painless hematuria can be due to even cancer, urinary tract cancer. So just not painless hematuria by itself, but in any urinary tract cancer, you don't generally get reduced GFR. So if someone has come to you with reduced GFR and then they also have hematuria, then and no pain, nothing, so maybe you can again consider a glomerular disease. Tubular interstitial disease, how do you?
Nocturia will be one symptoms. Patient can have the nocturia or the anemia disproportionate to the renal dysfunction.
Yeah.
And other than that, sir, acid base, if you are taking the investigation, then acid base imbalance.
Clinically also they will have more bony pains. Interstitial
Yes.
patients will have more bony pains as compared to.
So there may be skeletal
Skeletal,
complaints,
yes.
right? Short stature in younger people, or other type of skeletal deformities, bony pains, those kind of things. Anemia out of proportion to whatever kidney failure that person has. So those will indicate the presence of tubular interstitial disease. Vascular disease?
Vascular, sir, uncontrolled blood pressure. Otherwise.
What else? The other thing is presence of any vascular abnormality anywhere else, for example, asymmetric pulses,
Or the
right? Those kind of things will lead you. So please do that examination, look for pulse asymmetry, all of that. We don't do that now in the clinic often. But if someone comes to you for the first time, at least the first examination should always include all this, that you look for all the pulses, especially if someone has come to you with hypertension. Sometimes people may come to you with kidney disease even without very prominent hypertension, but may have ischemic kidney disease, especially elderly people and so on. So please do look for pulses in these individuals. What are the other unexplained causes of kidney failure?
Sir, CKD, we call it
No, don't say CKD, please don't. We are not talking CKD here.
Sir, other causes
Someone comes to you with kidney failure,
sir,
you
urinary
can't.
tract infection, asymptomatic bacteriuria or pyelonephritis, or the urinary tract infection.
That is obvious, right? Generally, someone asymptomatic bacteria doesn't cause kidney failure, right? So someone comes to you with kidney failure in the clinic, but there is no telltale evidence of glomerular disease, tubular interstitial disease, etc. What are the conditions that come to your mind?
So, other system can be because of the other system involvement, like cardiac. Because of the cardiac, there is the renal involvement, or the hepatic dysfunction that involve the kidneys.
Yeah, but those conditions will be obvious, right? If there is a cardiac disease, you will see the evidence of cardiac disease on physical examination or history. Similarly, liver disease will be obvious if it is there.
What we are trying to get into, one of the ways is what sir said in 4 compartment wise.
Sir.
We have other 10 nephrotic syndrome, 10 syndromes in CKD, right? Sir. In this kidney. So you have to think of those syndromes and what other syndromes you can fit this patient into. What are the 10 syndromes?
Sir, asymptomatic bacteriuria, nephrotic syndrome, nephritic syndrome, and then chronic kidney disease, and then nephrolithiasis or the renal stone disease, and then renal vascular hypertension, and two more I forgot some.
Yeah, those syndromes are there, but then there are certain things again that depends on the context. For example, if someone, let's say a 65-year-old person comes to you with unexplained kidney failure, what do you suspect?
Sir, no hypertension we can.
There is no hypertension, or there is mild hypertension. A 65-year-old person can have hypertension even otherwise.
Lower urinary tract obstruction.
Yeah, obstruction you should always rule out in any condition, but there are other things you should always
Drugs history, sir?
think of. Yeah, drug history is a very important one that you should always think of. Always take drug history whenever you are talking to a patient with kidney disease. Ask about history of whatever medications they have taken. Don't dismiss anything, whether it is standard Western medicine or non-traditional type of medicines. Just non-traditional or whatever. From other side, you can call them traditional medicines. Then there are conditions like multiple myeloma. So that is something you should always. If you don't think of it, you will not look for it. And if you don't look for it, you will miss the diagnosis, which has quite often happened, right? Then the other thing which you mentioned, but again, we don't often look for it, is ischemic kidney disease. That's also not usually investigated. Quite often, you make a diagnosis of kidney failure due to hypertension. Now, please remember that hypertension by itself does not cause kidney failure, unless it is severe, malignant hypertension, that kind of a thing. If you go to dialysis units, you will see that most of your patients carry diagnosis of hypertensive kidney disease or something like that. A large proportion of those patients. That simply means that whoever is making the diagnosis has been lazy and not fully investigated or tried to understand what has been the cause of kidney disease in a given individual. Especially hypertension, which has been there only for the last 1 or 2 years, is very unlikely to have caused kidney failure. So for hypertension to have hypertension definitely contributes to kidney failure. So anyone with any kidney disease, if the hypertension has not been reasonably well controlled, it will worsen the development of kidney failure. But by itself, it rarely causes kidney failure unless it is severe or very long standing and so on and so forth.
It's an aggravating factor, not the initiating factor.
Yeah, not the initiating factor or even the sole factor for progression to end stage kidney failure. Rarely. So that's something worth remembering for all of us.
This shift has come in the last decade or maybe 2 decades, and that hypertension was previously labeled as a cause, benign
not
nephrosclerosis.
Really. I mean, benign nephrosclerosis was called benign because we thought that it was not causing kidney disease, right? So in fact, it was thought that you need to have some degree of nephrosclerosis for the kidneys to be able to be able to cope up with that degree of blood pressure. That is why it was thought of as an adaptive response rather than a maladaptive response. When you have failure, that's a maladaptive response. So hypertension by itself was not thought to be, but somehow it simply has entered our consciousness as hypertensive kidney disease as the diagnosis being presented. So now let's come back to this case, right? And let's consider the investigations. So the investigation, what is the most striking feature of this investigation, which wasn't expected?
Sir, shrunken bilateral kidneys.
Yeah, the shrunken bilateral kidneys. Why do you think it is unexpected?
Sir, because the previous blood pressure readings was normal and the creatinine although was not checked in the
blood pressure can be normal in people with shrunken kidneys also, right? When will it be normal?
In this chronic interstitial.
Yeah, if it's a tubular interstitial disorder, the kidneys may shrink, but the blood pressure will still be normal, right? And so that is not a surprise, entirely a surprise. But why is it a surprise?
Sir, creatinine was also, but not checked during the whole gestational period, sir. Creatinine the first time checked, so it may be missed.
The creatinine was not checked in the early visits?
Yes, sir. Not done in the early antenatal visits, sir.
Should it be done or not? What is the recommendation?
It should be done, sir. In the first visit, at least.
First visit should always be done, right? Sir. Kidney function should be tested. Proteinuria should be looked for. In fact, in some of the guidelines, the OBGYN guidelines, it is recommended that it should be done in every visit, but then not everyone or every society agrees with this. So at least the first visit, every group agrees that yes, all these tests should be done. So it's somewhat surprising that it wasn't done in the first visit in this case. But what else is unusual in the presence of small kidneys and in the presence of serum creatinine of 2 to 3 at that time?
Great.
Yeah, the fact that she carried on for 32 weeks and you haven't told me, you said that she gave birth to a healthy baby.
So,
Right.
weight was lesser. It was 1.5 kg. So
1.5, but she was at 32 weeks, right?
Yes, sir.
Yeah. So what is the
otherwise-
normal? I can't tell you what would be the expected normal weight at 32 weeks.
Sir, around the 1.8 or 1.5 to 1.8 generally.
Yeah, so it is
considered
not
normal.
low, right?
Not
I mean,
that
from
much low, sir.
at least to my understanding, I don't know what is the normal expected weight at this stage. So it is the baby was not small for age,
Eight, sir.
at least to my understanding, and so that is unusual, right? So for someone who has small shrunken kidneys and possibly pre-existing kidney failure, which not kidney failure but compromised
Disease.
kidney function, so that's very unusual in this case. But subsequently, was the ultrasound repeated? The first thing we
Sir,
always
yes, sir.
doubt is the ultrasound finding itself,
Yes, sir. It was repeated on multiple occasions.
and
sir.
it
Yes, sir. It was the
always
same.
showed
sir.
small kidneys.
Sir. Yes. Sir.
Right. So those are unusual features for sure. Let's say you had seen her at that 31 week period of gestation. She came to you with edema, blood pressure was 200 by 100, and there was no proteinuria, let's say, or there was mild edema, blood pressure was high. At that time, if you wanted to confirm whether the likelihood of preeclampsia was high or not, what else will you do?
Sir, nowadays there are multiple biomarkers are available for the.
What are the biomarkers?
Sir, one recently in the published data is the ratio of SFLT1 to PIGF ratio. Sir, that is the anti-angiogenic factor to the angiogenic factor. So they decided as a value of 30 and the 85, sir. So if the value is ratio value is less than 30, then it is low risk, and if there is value is.
What does this mean? You have, I know you have remembered the values, so you are reciting those values, but what does it mean?
Sir, it means
SFLT1
there is
PLGF ratio.
It means there is the first milieu of this abnormal placentation, and now this second it happened at this stage, and these anti-angiogenic factors get more, and they suppress.
What is
the
anti-angiogenic factor?
Sir, like this soluble FMS like tyrosine kinase, it's
What is a
it's
soluble
released from the
FMS?
placenta, sir. Basically, abnormal placentation. Because of the abnormal placentation, its value gets increased. So it then
From where does it come?
sir, placental cytotrophoblast and the syncytotrophoblast, sir.
Yeah.
So it gets released, and generally the both values get balanced, but in the abnormal placentation this anti-angiogenic gets more. And
Why is it anti-angiogenic?
sir, it inhibits the vascular endothelial growth factor.
How does
and
it inhibit the vascular?
it binds, basically sir, it binds with the VGF, and then it inhibits the VGF and also the placental induced factor.
But from where this, what I am trying to understand is that you are right when you say that it is secreted by the placenta. But why is it not present in normal pregnancy?
Sir, because of the abnormal placentation that happened during the early, there must be any risk factor in the lady. So there must be, because of the risk factor, there is the abnormal placentation that happened in the early part of the pregnancy, most likely in the first trimester. But then in the third trimester, it gets visualized or in the form of the clinical symptoms, because at that time there is the second hit happens, and this because of that part.
At what gestation is this marker recommended?
Sir, third trimester, 32 weeks, 28 to 32 weeks generally recommended, sir. 28 weeks.
A little earlier.
So there are two time periods you can do it. You can do it even at 20 weeks to predict.
Yes, sir.
It's a predictor.
Predictor
Does not
at the
help you to
24
treat.
week, and
But the fact is, how it develops, so you have to know. So the name is SFLT1, right? So it is a soluble FMS-like tyrosine kinase, as you said. So normally, where is FLT1 found? Why is it called soluble? So normally, this FLT1 or FMS-like tyrosine kinase is found on the vascular endothelial cells. It is part of vascular. It is a receptor for VEGF or pro-angiogenic growth factors, right? So whenever VLGF has to act or other pro-angiogenic growth factors have to act, they go and they bind to this SFLT1, not S, FLT1 on the endothelial cells, and then they do their pro-angiogenic action. But in the situation of abnormal placentation, the FLT1, which should have been bound to endothelial cells, it gets released. So only the extracellular fragment, it comes out into the bloodstream, and that is why it is called soluble, because then it comes into the bloodstream and it circulates in the bloodstream. So that's how it becomes soluble FLT1. When it circulates in the bloodstream, it binds with with VEGF in the bloodstream itself and prevents it from going and attaching to its receptors on the endothelial cells, vascular endothelial cells, and so therefore the balance gets tilted in favor of anti-angiogenic state overall. So normally pregnancy is a pro-angiogenic state, but in this situation the balance gets tilted to anti-angiogenic state. And so because now this SFLT1, which is being released by the placenta, is circulating through the entire maternal circulation, so it causes anti-angiogenic situation in all organs of the body, right? And that is why in the liver you get HELP syndrome if there is if the release of SFLT1 is really there is a surge, then if the liver vascular endothelium is it becomes compromised and you get HELP syndrome. In the kidneys you get endotheliosis of the glomerular epithelium, endothelium, etc. So that is why the anti-angiogenic state becomes important. So either you can look at the so the other pro-angiogenic factor which is present is placental growth factor, which is elaborated by placenta itself. So either you can look at the level of the placental growth factor itself, or you can look at the ratio of SFLT1 and PLGF. So this is also important because SFLT1 PLGF ratio, for this ratio you have to measure separately SFLT1, you have to measure separately PLGF, and then you take a ratio just like you do for ACR, right? So it's important to also know what kind of SFLT1 measurement kit you are using. So there are certain kits which measure only free SFLT1, whereas there are other types of kits which measure both free SFLT1 and SFLT1 which is bound to PLGF. So if you somehow use a kit, so you should know which kit your lab uses, because sometimes the lab people don't understand this difference in pathophysiology, and they will order whichever kit is available in the market thinking that it is SFLT1 kit. And if it is a kit that measures both free and bound, then it will give you a falsely high value of SFLT1 rather than falsely high value of PLGF, because it is also measuring the bound PLGF, right? So that's important for us to distinguish. So just like you have to know what method is being used for serum creatinine assay in your lab. Is it enzymatic assay or is it Jaffe's assay, because there are differences. What method is being used for? Can anyone tell me how is serum albumin test done in your lab?
Bromocresol green, bromocresol purple and bromocresol green generally.
Yeah, what is the difference between the two?
Sir, values 0.5 is the difference between the lab values.
Right, so there is 0.5 to 1 is the difference between the two methods, And so you should know, because in which method your lab uses. Only then can you interpret the value with confidence. Because if you use different methods at different times, then you will say, oh, the albumin is going up or down, right? Similarly here also, so that's why. So we are digressing a little bit into laboratory methods, etc. But I think it's important for all of us to know this as well. So we come back to, so you can use this PLGF level or SFLT1 PLGF ratio either at 20 weeks to predict the development of preeclampsia over the next 2 weeks. Because it changes, it keeps changing, or you can measure it later on around 32 weeks, as you just said as well. Okay.
What's your syndromic diagnosis for this case? You said creatinine was 2 when she was diagnosed for the first time, around 32 weeks, and down how many months down the line she is end stage CKD. It has progressed pretty fast. So what are the differential diagnoses for this primary? What is the primary disease here?
Sir, as per the history, she was having the bilateral shrunken kidney. So, and there is the exposure.
Forget the shrunken kidney. No?
Sir.
If you say shrunken kidney, then interstitial disease, and it's the end of the story. Interstitial disease progressed this fast?
But sir, she was not compliant to treatment. She took the indigenous medications for.
Is hypertension a common feature at creatinine 2 of interstitial disease?
No, sir.
Then?
Generally less likely, sir. But
what is? How is it progressed so fast? So it's just the interstitial disease and some other cause for hypertension.
It can be
and
there can be the superimposed other cause, sir. But as per the history suggestive, there was no any other history was not.
Was she compliant to the hypertension treatment?
No, sir. That's the reason she progressed so fast, sir. She was not compliant to the antihypertensive treatment, and then took the indigenous medicine.
So what happened to her serum? So the serum creatinine was 2 at the time of initial diagnosis, right? And then she delivered. What happened to the serum creatinine at the time of after delivery?
After delivery, when she discharged, that time 3.5, sir.
3.5. So it had already gone up,
Sir.
right? So 3.5. Why do you think, is it rapid? Does it indicate rapid progression? What does it indicate?
Sir, generally, if there was CKD in the 3rd trimester and during the delivery, there is the vascular hemodynamic changes that can affect the GFR decline, sir. As per her creatinine and AC is already fitting in the CKD stage 3, sir. So
yeah, so although it's very difficult to say, but you're right in your hypothesis that generally during pregnancy there is an increase in GFR from whatever is the baseline.
Sir.
Although it's a feature in normal healthy women, right?
Yes.
But in someone who has a pre-existing decline in his GFR, does the GFR increase? We don't know. But the fact is, in this patient, the GFR even during the pregnancy itself declined from 2, the creatinine went up to 3.5 just after delivery, right? I mean that's what you're saying. And from 3.5, a rise of 6 doesn't take much. Why?
Sir, over the 6 months, but that was.
It's not a question of over 6 months,
Sir.
because the later on the rise in serum creatinine is exponential with regard to the eGFR. So the decline in eGFR will be only small.
Sir.
So it's not like 1 to 2 means the same as 2 to 3,
Sir.
right? So that's important. So I wouldn't perhaps give too much significance to maybe a relatively rapid rise in serum creatinine itself. That is something that the patients get worried about, but it is for us to explain to them that it doesn't mean that now the kidney disease is progressing fast and it was progressing slowly earlier.
Yes.
It was progressing as fast or maybe even faster earlier, right? But just because our kidneys have that adaptive capacity so that the serum creatinine doesn't rise in the early stages of loss of kidney function. So that's an important feature we should not forget. But there were a few other things also. Her hemoglobin was not too bad. Her hemoglobin was 10, you were saying, when the initial diagnosis was made. So there are atypical features in this case.
Yes.
I don't know whether at that time what were the platelet counts and so on.
Sir, now we evaluated her for the transplant workup, so we checked all the previous investigations and the records, sir. So as per the previous record, there was no thrombocytopenia, sir, and HB was pretty well as per her presentation, sir. It was 9 and 10 in all ANC visits, sir, and the blood pressure readings was also normal previously. And
Normal? When was?
ANC visits, sir. Previous ANC visits. We saw the previous ANC visits that was recorded normal, sir.
Right.
And now, sir, she progressed more likely because of the non-compliance.
Non-compliance to?
Antihypertensive medications, and also the another.
But the hypertension came, right? I mean, hypertension. So that's quite unusual. The kidneys were already small. So it's not like she has progressed now. The kidneys were already small at that time itself. So the progression has already happened. So again, don't think that the progression has taken place only now in this case.
Sir, evaluated for other causes also, because she had the first trimester pregnancy loss and planning for the transplant now. So lupus and all, we did the investigations, all were negative, sir.
Yeah. Okay. So now you are planning a kidney transplant
Sir.
for her?
Yes, sir.
What will be the other considerations now for kidney transplant in this case?
Sir, hypertension, TMA, we also.
I think the main thing to now worry about is whether she has something which will recur in the graft.
Yes, sir.
Right? That's the main thing we worry about, because the kidneys are already gone. These native kidneys are already gone, right? So what are the conditions that can present in this manner and also potentially recur in the graft?
Atypical HOS.
Yeah, so thrombotic microangiopathy, so we should look for that.
Sir.
So I would still complete her workup from that perspective. What tests will you want to do?
Sir, complement factors, especially the complement factor H, I, and the anti-CFH antibodies, and also if available then complement factor B and complement factor B, and other than that MCP.
Yeah,
can
those tests are not easily available in
Yes.
India. You know, there are very few laboratories that do it. I think All India Institute might do it. The complement factor H and anti-CFH antibodies, etc. I think it is worthwhile getting it done. It is also possibly worthwhile getting a genetic panel for. So let's say you are suspecting atypical HUS and you want to send off a genetic test. What will you order?
Sir,
What will you tell the lab, the genetics lab? What should they do?
clinical genome sequencing. Clinical genome sequencing.
What is clinical genome sequencing?
As per the disease, sir, there are the whole exome genome sequencing, clinical exome genome sequencing, and then next generation.
So clinical genome. So what does clinical genome sequencing mean? I don't
basically
understand.
they will do the complement. If we mention the history, clinical history of suspecting the HUS, then they will do all the.
So you will leave it to them to decide what they want to do.
We'll mention the complement, this complement factor H, anti-CFH antibody I, and the factor B.
So you have to look for. You have to sequence all the complement related genes, right? Complement factors and complement regulatory factors, number one. So one is sequencing, but what else do you need to do in this situation?
For TTP also.
What is the type of genetic abnormalities that that are seen in this situation? What are the different types of genetic abnormalities that can cause disease? Anybody? Any clinical situation, what are the different types of genetic abnormalities? So you can have mutations, and mutations can be, you said deletion is one. What are the other types of mutation?
Frame shift.
What does frame shift mutation do? What does what does deletion do?
There will be the loss of, sir, in the deletion there will be the loss of one base pair, so the next
Deletion will be one base pair?
it means the next sequence amino acid will be the different, sir, in the chains.
That is not deletion. Deletion is generally chunks of chromosome are deleted, and if chunks of chromosome are deleted, then the protein will be severely truncated, or it may even not be formed, right? Or it may be misfolded, badly misfolded, and so poorly functioning protein. So that is deletion. Then someone said, what? Missense?
Frame shift.
Frame shift. What does frame shift mean? So frame shift is the situation that you are saying, that one base is lost. So the frame shifts.
Next sequence.
Let's say there is ATGC whatever, and then T drops, then AGC, that becomes the frame. And so that when the frame shifts, then the amino acid sequence will change entirely, right? Then there is missense mutation, in which one of the nucleotides is replaced by another, and that changes the amino acid. In some instances, the amino acid may not change because more than one codon also codes for the same amino acid. In other instances, amino acids may change. So these are the type of, these are the type of mutations you will detect by sequencing, what you are saying. But then there are another type of genetic abnormality which is called long duplications. So duplication means the same gene is duplicated in sequence, and that sequencing generally doesn't pick up because the sequencing that we do, the Sanger sequencing, is not sensitive enough for that. So they do what is called MLPA, multiplex ligation and amplification, for that. So you will have to specifically order MLPA for that happens in the complement gene abnormality. So you have to order for sequencing for the complement gene panel, and along with that you will have to order MLP as well. Generally they will know. If you tell them what to, they will do it, but you should know what you are asking for, right? So that's also important to keep in mind. And MLPA is tricky because many laboratories cannot do it well, and so often they will give you a report saying that there is duplication when there is no duplication. So that is why you have to find a laboratory which can do it properly, and then only go to that laboratory for MLPA. It's important. So let's say someone does complement gene panel and find something. What does that mean?
Sir, if it is clinically significant, they will also mention that it is significant.
Yeah, they will tell you there is some abnormality. So my question is that, do all the complement gene related abnormalities you will find, do they mean the same thing even if it is pathologically significant? Do they all mean the same thing?
Sir, especially in case of atypical HUS, sir, if we found the complement factor as related antibodies, then we can treat pre-transplant and can continue the treatment post-transplant. But if there is abnormality for which the treatment is not available, especially the factor I or the MCP and the other, then we have to explain the risk of reoccurrence to the recipient.
Yeah, so the one thing to say is that not every complement gene abnormality will mean that recurrence is guaranteed. There are some where the risk of recurrence is low. In that case, you can go ahead with transplant. In some instances, you may need to use prophylaxis with eculizumab or other similar therapies. Sometimes in the postpartum HUS type situation, what happens is that the HUS is triggered by the pregnancy itself, and because there was this initiating factor which was something to do with pregnancy, given that it has now gone away, it is possible that it may not recur again, right? So that's that's something which we have to balance, and we have to keep that in mind. Right. So not in every situation we have to always say that okay, transplant now cannot be done just because there is a complement gene abnormality.
Can we go back to a bit of physiology back again? I thought I'll ask few questions.
Go ahead. Yeah, sure.
GFR is increased in pregnancy, right? So, and when we treat other patients in of kidney diseases, we give them drugs which will, what happens when the GFR increases in pregnancy, it increases the it decreases the creatinine because of the increased GFR, right? In normal kidney disease patients, when the disease progresses, we tend to give them drugs which will reduce the GFR. So in the intraglomerular hypertension that happens is the core of kidney disease problems. The GFR increases here also. So why there is no damage to kidney disease to the kidney in pregnancy, even if the GFR is increased so much? Like what happens in diabetes, the GFR increases initially, right? In pregnancy also it increases. Diabetes damages, pregnancy does not.
So
For a hypothetical situation, if a female is pregnant, let's say 5 times, 10 times, 9 into 10, 90 months have passed in high GFR state, it still does not damage the kidney. What is the difference in the two?
Because of the adaptation mechanism, sir. If in the normal pregnancy, when the GFR increase, basically because of the increase in the renal blood flow, the plasma flow. So if that happens, then there will be the RAS system activation also will be there. So that part will be balanced by that.
RAS activation in normal pregnancy?
In the normal pregnancy, there will be the insensitivity to the angiotensin, especially, sir. So that part will be balanced by that. But in the other conditions, like in the diabetes and all, there will be the after that initial rise in the GFR is basically because of the RAS system activation. So that part, that's why we generally initially start in the diabetes with the ACE inhibitors and ARB.
The adaptation is important. So the vasculature of during pregnancy is relatively, not absolutely, relatively immune to those vasopressors like angiotensin 2 and other things. So that's why it is not, I hope the message is, that's one important aspect. What are the other normal changes in pregnancy, if you can, if there's any first year here? First year, if anyone, it's not a third year level question, but if you can, what are the normal changes in kidney during pregnancy?
GFR increase up to
That's one. What else?
And there is a vasodilation of the vessels, so blood pressure also decrease less than 120. We have to consider normal if it increase because of that increase placental hormone. So
lower blood pressure.
Blood pressure will lower.
What else? Anyone else? What else? Other pregnancy changes? Normal pregnancy changes. You have to know the normal to know the abnormal, right? Any size changes in the kidney?
Yes, sir. Yes.
How much?
Increase size of the kidney due to increase in the GFR to 1.5 times normal.
Yeah, up to 50% it can, the whole volume can increase up to 50%. What else? They might come running to you saying we have stone in the kidney on one side. We can't visualize the stone, but there might be a stone because there is a swelling.
Increase in the uterus, it will compress over the ureter.
You have to reassure them it not, because you can't do a CT.
Yes.
So you have to reassure them this could be the
Because of
normal changes in the pregnancy and not some obstruction.
no.
Plasma volume, what happens to plasma?
Hydrosis of the kidney can be.
Yeah, what happens to plasma volume?
Plasma volume increase. Plasma volume increase up to
coagulation factors, plasma volume. It's a procoagulant state or anticoagulant, or it's neutral? Pregnancy.
Pregnancy.
Okay. Any other physiological changes? It's a 10 number question. Hematological changes, structural changes. What are the coagulation factors that increase?
चलो पढ़ के नहीं आए तो
प्रेगनेंसी का तो थोड़ा सा पढ़ना ही पड़ेगा.
Why do these changes happen? There must be a reason, right? Do you ever wonder why do these changes happen?
Sir, hormonal changes because of the prostaglandin.
Why is it necessary?
Progesterone, basically the pregnancy.
Why does the body need these changes?
To continue the pregnancy, there will be the continuous progesterone, sir, initially from the persistence of carpus luteum and later on to the placenta. So there will be the persistent constant level of the progesterone and also the prostaglandin, and later on along with that there will be the relaxin. So the nitric oxide related vasodilation will be there, sir. So because of the vasodilation and the decrease in the systemic vascular resistance, there will be the compensatory adaptation mechanism. So there will be the increase in cardiac output or the plasma volume, renal blood flow, and the increase in the GFR or the decrease in hematocrit. These changes happen.
Does it also serve any physiological function?
Sir,
This increase in plasma volume?
sir, adaptations to that low cardiac load, so because of the systemic vascular resistance is decreased, so it will compensate by increasing the cardiac output.
Yeah, so it's just an adaptive response is what you are saying. There is no other function to it.
Meet the basic need for the.
Yeah, so adaptive response, that's why it is called adaptive, because it is helping you get over something, so that is why it is adaptive. Right. Okay.
What are the antihypertensives you gave during pregnancy?
Sir,
If you encounter a state of 200/100, what antihypertensives will you give?
Sir, labetalol generally nowadays we prefer to give, and if not available, then in some center nifedipine also used, and that is also not available, then methyl dopa can used.
Okay.
And other than that, sir, other CCBs are not studied for the pregnancy, sir, like amlodipine and all. And in some cases, clonidine can be used, but that is in the later resort, sir. Initially, we start with the labetalol or nifedipine.
She had swelling also, she had high BP also.
Sir, diuretics we will not
Why?
give, sir, because there will be the chances of oligohydramnios, so fetal compromise, placental perfusion will decrease, and then fetal compromise.
Fetal compromise
be
can
there,
happen with diuretics.
Okay, any questions you guys have? Any questions you have for us?
Sir, I am confused about the diagnosis because we are planning the transplant, but still not convinced with the chronic interstitial nephritis as the cause of CKD. By the presentation, like right now also
Right,
needing
so you are right. In many instances, in people with kidney disease, it is not possible to determine what is the cause. So we have to simply accept at that time that we don't know what was the initiating event. So that is why you have to decide what is the goal at this point. The goal is for her to get a kidney transplant, and you just want to find out if she has anything that will recur in the graft. So that's the only thing you can do. That's the best you can do. Beyond that, it really doesn't matter so far as management is concerned as to what does she have, right? And like I said, it is not uncommon at all in nephrology world that we have people who come to you with advanced kidney failure and you are simply not able to decide what was the initiating event. So your dilemma is not unusual or not something that you will face only once, not again. You will face this multiple times in your career. All of you will face it. So just make sure that you don't miss anything that can land her into problem after transplant, and you should be fine. Other than that,
Yes.
You say that you have repeatedly confirmed that the kidneys are indeed small and there is no other abnormality. So that's it.
So if the kidney size was normal, would you have biopsied this patient?
After pregnancy.
During pregnancy, can you biopsy? Should you biopsy?
Sir, she was presented in third trimester. So
If at all, let's say 28 weeks, same scenario at 28 weeks, 200 BP, whatever proteinuria, normal size kidney.
Sir, if the same scenario, then we will wait till the delivery, and post delivery we plan the biopsy, because it will not change the.
When is it safe to do kidney biopsy during
In the
pregnancy?
first and the early second trimester, sir. First trimester and early second trimester, sir.
First trimester, is it
It's the
safe?
safest.
We do biopsy in the first trimester?
Sir, generally obstetrician denied because of the risk of the early abortion, but from the nephrology point it is safe, but generally we do in the second trimester. In
Most
the
of the
clinical
interventions
practice,
are allowed in the second.
second trimester.
So
Yeah, first trimester traditionally biopsies are not, or any intervention is not recommended. If it is essential, for example, if someone presents with RPGN, then you will disregard the risk to the fetus, because it becomes much more important to care for the mother. And of course you have to inform the family and all of that about the potential risks, and you will go ahead and do a biopsy in that situation. That's a different matter altogether. But if it's an elective biopsy, then
trimester.
possibly you will wait the first trimester out and do it during the second trimester. And again, not do it during the third trimester.
it's important. You can do it in second trimester. There's a glomerular disease. Some types of immunosuppressions are allowed during pregnancy. So second trimester is the time you can biopsy, give some immunosuppression, save the kidney, and probably the pregnancy will last till 36 weeks. If you don't do it, she will abort earlier, risk to fetus, risk to her, and the kidney will be gone like this.
Let's say someone with a woman with a creatinine of with an EGFR of 15, between 15 and 20, right, who is not on dialysis yet, is otherwise well compensated, becomes pregnant. It is unusual, but it can happen, right? Then she is not practicing any contraception and becomes pregnant. How will you advise her?
Sir, we'll advise her for the maternal outcomes and the fetal outcomes, sir, and what precautions she will be needed in the next 9 months, and also what can happen to her during the pregnancy. How will be the
So again, it depends on at what stage of gestation does she come to you, right? Let's say she comes to you, she has missed a period, and she comes to you. She did a pregnancy test at home and found that it was positive. What will you say to her?
Sir, firstly, we'll advise her for the maternal outcome, so that there will be the higher chances of that she may require dialysis during the pregnancy, and most likely in the some cases she can progress to the end stage.
What is the purpose of giving this advice? What are you trying to
Sir, if she
discuss with her?
Termination of the pregnancy, if she can.
Termination of
Consider.
pregnancy.
If she can consider.
So that is the first question they will want to know, and you also might want to tackle, right? What to do with, should she continue with this pregnancy or not? So what are the factors that will come into your mind?
Sir,
One is, you said, maternal outcome. The second is
fetal outcome.
fetal outcome. So what is the maternal outcome scenario in this situation where someone has come to you just as they have discovered that they are pregnant?
Sir, there will be the high chances of blood pressure rise or the uncontrolled hypertension, worsening of the renal function,
Yeah.
decrease in the GFR, may need the dialysis, and if she need the dialysis, then that dialysis duration will be prolonged, and she can have the other feature of early that will be the fetal outcome, sir. Then in the fetal outcome,
Say that again.
pregnancy outcome generally.
So if she needs dialysis, let's
Yes,
say
sir.
she doesn't need dialysis, then what is the likelihood of, what is the fetal outcome like?
Small for gestational age.
So one is that it is very unlikely that this woman will be able to carry her pregnancy to term, right? Uncomplicated. Anyone with a very low GFR has just become pregnant, most likely they will not be able to carry the pregnancy to term uncomplicated. So that is the first thing for this person to remember. Even if, let's say, she is keen that, okay, I do want to continue my pregnancy, then you may have to tell her that in that case, if to ensure that you give maximum chance to the fetus, you may need to even start dialysis preemptively, right? Because you can't, because the more uremic the milieu is, the more chances are of a poor fetal outcome.
Yes.
So you may have to start dialysis early, you may have to give dialysis even more frequently than, so all that information needs to be shared with the mother. So one is the maternal outcome, which you said correctly, the risk of deterioration of kidney function, worsening of blood pressure and whatnot, but also equally, because some may still want to argue that I will want to carry my pregnancy still, but you have to tell them that likelihood of this going to term is unlikely. That is why I was surprised. The first thing I said about this woman is that she went on till about 32 weeks despite the fact that the kidneys are small, which is an indirect indicator that she has chronic disease. So that's one. And again, like we just said, if she still insists, then you have to appropriately prepare her with early dialysis, more frequent dialysis. Despite the fact that she may not yet develop the typical indication for dialysis. Typical indication is if someone has hyperkalemia, fluid overload, acidosis, etc. So if such a person still wants to carry that pregnancy along, then they will require dialysis earlier. Between hemodialysis and peritoneal dialysis, if you have to choose, then what advice will you give them?
Sir, in this scenario, if the patient is not on dialysis, then we'll choose the hemodialysis as compared to peritoneal dialysis. As such, sir, there was no contraindication for peritoneal dialysis, but if she develops the peritonitis during the further course, so there can be the chances of premature rupture. Or
if she develops catheter-related sepsis, then I mean complications are possible
sir, other thing
with
is,
any process.
Other
procedure.
thing, if the pregnancy goes advanced, then there will be the abdominal distension more, and the chances of respiratory distress will be more. So we need to do the
So towards if she is lucky and she carries the pregnancy that far, then it may be an issue. But I think in the early period of the pregnancy, peritoneal dialysis is a reasonably good alternative compared to hemodialysis, because it is much more gentle in terms of the hemodynamic impact it has on the circulation. So if someone can do peritoneal dialysis, and she can do it at home and much less disruption of lifestyle, because hemodialysis, if you give, you'll have to give more frequent hemodialysis, all that kind of stuff. But of course, towards as she comes to term, then possibly peritoneal dialysis may not be technically possible to continue, and then you may have to shift her to hemodialysis at that time. Right, any other question?
One last post-transplant, if she wants to get pregnant again after transplant, how will you counsel her?
Sir, post-transplant period, firstly we'll see the duration after the transplant, how generally in the initial 1 year we try to counsel the patient to avoid the pregnancy. And then we'll see the other factors, sir. The baseline creatinine C achieved post-transplant, that should not be, generally we consider as less than 1.5 is the safer side. And then we can see the, if there is how is the post-transplant core, is there any recent infection, especially the viral infection, CMV or the BKV. And we also see the rejections, if she has the rejection, because we need to shift the some immunosuppression, change over to the immunosuppression. So if she had the past history of rejection,
so she's stable graft function after 1 year.
Sir.
How will, what next?
Sir, if all things are fitting in the criteria, then we can change the, especially the antiproliferative mycophenolate mofetil to the azathioprine, and for at least of the 6 weeks, but generally 6 months if we can do, and then we can advise her to go for the pregnancy. And we also looked the creatinine trend during that change over time, if there is any rise in the creatinine or not. If not there, then she can go.
What did you say?
So immunosuppression changed from MMF to azathioprine, and if we are changing the MMF to azathioprine, then we have to see the graft function during that time. If there is
Why specifically during pregnancy?
No, sir. Before
Post pregnancy.
Before
After, now this, if this lady
Post-transplant.
Sir.
Yeah, I mean that is why are you saying this? Is there any increase in the risk of graft dysfunction after conversion from MMF
Generally
to
less
azathioprine?
likely, but if there is the previous history of rejection, then there are can be the chances. Like
Where have you read this? What is the evidence that supports
Sir,
this?
Nowadays we consider more potent MMF as compared to azathioprine.
More potent in what way?
In the graft outcomes.
There is no data, which shows that MMF is superior to azathioprine in terms of graft outcomes anywhere. In fact, there are quite a few papers which have compared MMF and azathioprine and shown equivalent outcomes from Dr. Emotzi's group and other groups as well. So we all use now MMF, and it's become standard of care. So it is used, but I don't think there is any reason to suspect that because we shift someone from MMF to azathioprine, their risk is increased for of development of rejection or anything like that. Obviously, you monitor everyone, but not just because the shift has taken place. If you have to monitor something, you monitor the counts. So, what do you do before you shift or put anyone on azathioprine?
TPMT activity, enzyme TPMT activity will check, sir.
Activity you will check. Do you check activity?
I mean, enzyme activity checks.
What test do you order?
Enzyme, if there is positivity or not. So if
it's a mutation, right?
Yes, sir. So if there is mutation, positivity or not, if not there, then we can start. But if there is the mutation, then there will be the chances of leukopenia and the.
So you don't look for activity. You look for mutation in TPMT gene and NUDT15 gene. There are two genes which are responsible for azathioprine metabolism, and both of them can be either homozygous mutation or heterozygous mutation. If there is homozygous mutation, then the likelihood of development of leukopenia is very high, and you should avoid any shift or use very low dose if at all, right? But if it is heterozygous, you can still use it, although you should use smaller dosage, which is half to 1/4. And if so, you have to look for mutation in both the genes and see whether there is any. If both the genes are normal, then there is no problem. If both the genes are abnormal, then you should definitely not change. If one of the genes is normal, the other one is abnormal, then again you need to choose depending on the degree of homozygosity, heterozygosity, what do you want to do. So that's the important bit. But otherwise, there is no. I don't think you should worry about increased risk of rejection during switch. Monitoring continues as usual. You monitor everyone for rejection depending on their post-transplant period.